approximately 20% of reported AIDS cases actually hadn't changed for years. There was no difference in that. I think we saw that upward trend to 20% in the sort of latter part of the 1990s. But by the 2000s, it was pretty steady. The other thing about that, though, was that of the women that were tested and who tested positive, a quarter of them were identified by themselves as Aboriginal or from First Nations communities. And we know that that's way higher than the proportion of Aboriginal and First Nations women in BC, and that is a great concern. And the other thing, though, that we found, because the idea was that if you test, the information was, and one of the reasons for this whole program was that at a certain point, quite a lot sooner after testing positive, way before you got AIDS diseases, you could go on treatment. And what we did have was quite a lot of information that showed us that women were less likely to be on treatment, that once they were more likely to start later than other people, than men on treatment, and they were more likely to interrupt their treatment. And so when I composed my recommendations, I mean, when a lot of the consultations led me in this direction, we talked about trying to understand why that was. Now, I can go back again to this business about gendered plan. You know, we talk, men and women are different. We have different genetics, right? You don't know that. Physically, we're different. That's the sex difference. And we often talk about sex differences when we're looking at health of populations. But there's another concept, which is gender. And gender is the description of what it's like to be a woman or a man in a community, right? And so, so there's a whole lot of other things that come into gender. And gender would be, gender effect for women would be what's it like to have children to care for, or families. What's it like to be poor, generally speaking? What's it like not to feel safe in certain situations? And you know, we can see that these things also apply in a sense to men, but I believe that these things play out differently for women than they do for men. And I thought that probably this business about being able to engage in treatment had something to do with those factors, the gendered part of it, which is one of the arguments, or one of the reasons that I would say, let's have a look at our system to see whether it takes those things into account. And so that's not something that seems to be an easy concept for health planners and other people to take into their considerations. So where are we? Yeah, that's good. It's the same one that I've got here. Perfect. Okay. That's what I said, that talking to people, the many people that I talked to who are in this room and many who are not, and looking at the literature, generally supported the importance of taking gender into consideration. And when we then talk about something called women-centered, this is something that, you know, we spent endless hours talking about in BC Women's Hospital, because who else is going to talk about it if we don't talk about it? But what does that actually mean? And there are several concepts that are embedded in there. If you're going to try and make your care actually sensitive to women's needs, you need to make sure it's safe in their terms, right? So sometimes it's not safe for women to sit in, frankly, in mixed waiting rooms. Folks, you know, some women may not feel safe there. Just the same as some people with psychiatric illnesses may not feel safe there, or some younger people may not. So there's a lot, you know, it isn't just women to whom this applies, but most definitely does apply. But it's accessible, and by accessible we mean not only physically, if they've got some issues, but it's sort of close. I mean, I was talking to Vanna and Sue a minute ago about the advantage of having care right in a place where people live. I mean, this is about accessibility, also has to do with the attitude of the people that are providing the care. If you find them punitive, that's not actually accessible. Child-friendly or solutions for child care, that kind of thing. A non-punitive, I've already said, and something that, and this applies to all people who are coming into services for care, something that's at least coordinated, so you don't have to go 4 different places for related services. There's a lot more in a women-centered concept than that, but those are the ones that I decided to focus on in the report. Other consultations, yeah, they're just amazing. Really psychic. Oh, good. So Coco and I have been kind of joined at the hip for a while. So. Anyway, the other suggestions that came out of the consultation were that we needed to include a lot more about women's health if we were to do something women-centered. And I have to say, I've worked in this community lately again, and there are a few places where women can get comprehensive, what we call reproductive health services, but darn few, you know. So, you know, comprehensive means let's address the things that are important to people that move beyond the HIV question, for example. Peer support, the importance of understanding that people's main supports come from their families and friends, and often it's easier for people to understand issues if they're brought to them by people who they recognize and who are in their same community. People talk about something called navigation. This is what we used to call the OK word now in healthcare, but it is a way of connecting people to complex services. So navigation means you talk to somebody who can help you step your way through what seems to be a completely confusing and alien system. Knowledge-based approaches. We have great conversations with, and you're going to hear today, I think, from somebody from the Aisha Project, but great conversations with people, women especially, researchers who are really engaged in asking questions about how it really is to be a woman living in poverty or who is facing some of the issues that some of the women that we, some people who may have HIV are facing. And that they are somehow, if you're going to have a healthy system, healthy plan system, you really need to figure out how to bring in the information from the people themselves, but also from people who understand and are able to do the research. And there seemed to be a disconnection between what we call research or knowledge generation and actually services. And we really thought that there needed to be a very specific strategy, and I couldn't go into this in detail, but a specific strategy for Aboriginal women. At the time, as I said, I was doing this, there was a strategy. There was another group that was working on a strategy, but I heard many times that there was a lot of concern about women who came from rural communities, small communities into town, who couldn't get support in their communities, and they weren't getting the right kind of support here either. So that's why that was in there. I worked my way towards a suggested goal, and this is, I articulated this. Girls and women from all communities in BC will understand their risks for HIV, have the ability or the power to reduce that risk, and will feel safe to access and make best use, optimal use of high quality treatment and resources to protect them and care for themselves and ultimately for others. Because one of the things about being a woman, part of the gendered aspect, is that you are often a caregiver for other people. Now, I kind of in retrospect think it's ironic because the whole stop AIDS thing was about testing. I didn't mention testing once. It might have been a mistake, but I didn't. As I said, I was confused. In the report, I also suggested that there may be some principles to look at if you're going to try and do initiatives that had some staying power for women and actually made sense for them. And these are the ones that I suggested in that report, that they be gender informed. And as I said, there was no consensus at the senior levels that this was needed, but that was my job, so I had to say it. That it was inclusive, and that really meant that if you're going to do it, you can't carve off parts of the system and disqualify them for funding, and you certainly can't do this without engaging with people that you are trying to include, right? You need to figure that out. It should be, this is a catchphrase we all use, evidence-based, but gosh, there was a lot of information that wasn't being used, you know, from the research, in the research world. It needed coordination, and that has always been, when I left this community, I used to be the medical health officer here until a long time ago, 14 years ago. And when I left, the issue was coordination. And when I came back, I must say 2 years ago, I was so depressed. Because there's been a tenfold increase, honestly, in services. People have worked extremely hard on the diversity of services. As much as we see so many people who don't have what they need, I would say that the development is kind of staggering if you were out of the community for as long as I was. But what hadn't changed was that people did not still work together. Sure. Now there are certain clusters of people that do, but coordination hadn't really moved along that way. And then, you know, people get they get their territory. I think it's just what we are as people, right? We can understand this one. Don't bother me because I'm so busy with this one, I can't actually possibly do this. And anyway, this is our priority and might not be yours, that sort of thing. I mean, I think it's a normal human thing. It's very difficult to do it, but it needs to be done. And that the system is actually good at what it does. That it's not only available, but that you're not getting steered, that you're not getting poor treatment. Right? So competent and accessible, meaning that you are incorporating knowledge and doing it right as much as